Abby, I'm so glad you're here. Thank you for being here.
Thank you for having me. It's good to be back in a different capacity. I'm happy to talk about anything personal, but also I love talking about my work.
So tell us a little bit about your work and who you are and what you do.
So my name is Dr. Abby Bales. I am a board certified physical therapist and strength and conditioning specialist. I specialize in pelvic health and women's health as it relates to orthopedics. So I have a really strong background in sports and orthopedics and dance and movement. And I like to marry that with women's health, pelvic health to treat my patient population here in New York City. I own and run my own practice called Reform Physical Therapy.
Wonderful. And I wanted to have you on because pelvic floor dysfunction, problems with the pelvic floor are something that so many women experience, and we don't really talk about it that often. And I think people come to realize that they may benefit from some sort of pelvic floor therapy, almost sometimes when it's not too late, but kind of later in the game.
Mhm.
So let's just kind of dive right in. First of all, what is the pelvic floor? I think everyone, would benefit from hearing a little bit of just basic overview about that.
Sure. So the pelvic floor, everyone has a pelvic floor. If you have a pelvis, you have a pelvic floor, male, female, intersex, everyone has one. The main differences with female patients or people with uteruses is that we have three openings, not two. So where the pelvic floor supports, it supports the organs that are above, the uterus and everything that comes up above it, the bladder, the rectum and the anus. And then we have the openings, the anal opening, the urethral opening, and the vaginal opening. So it supports all of the things that all those different functions. It functions at the level of support. It functions at the level of being able to transfer pressure, changing of intra-abdominal pressure. And there's sexual function as well there with the pelvic floor. So the pelvic floor muscles are innervated by the same nerve line that innervates all of the bowel and bladder function, as well as the lower leg function. So it's L5S1 peroneal nerve. And the main thing that I like to think about the pelvic floor as is that in addition to sexual function and support is the big piece of transferring pressure. So the lumbar spine and the sacral spine, which is that lower part of the spinal column, is a really primary mover of force from where the foot hits the ground and transferring it up and out for the rest of the body. So when I look at the pelvic floor, it seems to me like it's the inner core. So we can see our glutes, we can see our abdomen, we can see our back muscles, but what is supporting us from the inside out and the bottom is the pelvic floor. And it reflects the diaphragm. So the diaphragm that is up just under your lungs is a muscle as well. The pelvic floor is the opposite to that at the bottom of the pelvis. So as the pressure from the abdomen changes, we see that the diaphragm can drop down, then the pelvic floor drops down in response. And the opposite is true. When the diaphragm goes up, the pelvic floor can go up. And that's to make sure that we don't squeeze the life out of the organs that are in between those two bodies of muscle. So it's a sling. That's a common visual, is that it's a sling. I like to think of it like a basket because it supports things that are tucked inside. And when I'm explaining an internal evaluation, that's the visual that I use. But it really is like a hammock, and it supports closing off and pinching off the urethra, being able to have really good functional bowel movements. And of course, it gets out of the way and extend in order to vaginally childbirth.
And who is at risk for problems with the pelvic floor or loosening or weakening of the pelvic floor?
So that's a very broad base of people. Kind of anyone who has a pelvic floor and is living for any length of time.
Mhm.
But I would say the primary people are people who have been pregnant, who have delivered either vaginal or C-section. So it's just the act of being pregnant, people who have had previous abdominal surgery or any sort of reproductive organ surgery. In the male population, people who we see a wide range of people who are like truck drivers who bounce a lot in their jobs, or who ride bicycles for long periods of time. But women's riding, gymnasts, people who have to produce, like I said, that transfer of force, that really very sharp transfer of force. But really, you're looking at anybody who it can really happen to anybody, pelvic floor dysfunction, because the nerve root is related to low back pain. You can also develop pelvic floor dysfunction as a result of having a back injury, which is more common. And so really it can span the spectrum. But when I really think about it, it's in my patient population, it's people who have given birth, people who have early onset menopause, and people who are athletic in those really sharp force, more anaerobic sports that are jumping sports.
And can you talk a little bit about how early menopause, because this is a question that comes up a lot, early menopause, how does that impact and cause pelvic floor dysfunction?
So when we're thinking about, we have to go all the way back to how muscles and bones develop, and we think about how estrogen supports muscle growth and maintenance, and estrogen and testosterone both together. But when we see in the absence of estrogen at an earlier stage, we see things like muscle wasting, sarcopenia. We see weakness. We see a lower level of energy, and thus, like, a person is not as active, so they're not maintaining that muscle mass over periods of time. So the hormones that are typically, in our bodies in order to support the maintenance and the growth of our muscle mass are greatly affected by having that early onset of menopause in your 20s or in your 30s, secondary to a chemical or a surgical menopause. So at the level of really at the cellular level, we're seeing a deficiency in hormones, and the pelvic floor muscles, I should say, are made up of the exact same muscle fibers as your quadriceps, as your biceps. It's the same muscle group. So the development and the maintenance of the pelvic floor musculature is exactly the same as everything else. So in the absence of hormones, so we think about how we think of like an older woman who's in her 80s, we see like they're not typically very muscular. They are typically more frail. We think of the pelvic floor as being directly affected and in equal measure to those muscles over time, as you lose that 8 to 10% every decade of your life. So when we have an early onset of menopause, we see people who are at higher risk for sarcopenia, and then of course bone density issues as well.
This is such an important topic because we've talked a lot recently, and the data shows that people are getting breast cancer at a younger age. They're going into menopause as a result of breast cancer treatment at a younger age. And I will say I think survivorship is, I don't want to say left pelvic floor rehab out of it, but a little bit it has. Like, I don't think we think about it as much as we do the other things, the cognitive dysfunction, the hot flashes, the joint pain. And I think because we don't talk about it as much, people are kind of not paying as much attention to it.
Sure. I think in general, we could generalize and say that the musculoskeletal system has been left out in general. We
Yes.
can say that pretty definitively, because we are just now seeing the barest start of an encouragement of movement in conjunction with treatment,
Mhm.
even during treatment, because we know what's coming ahead. We also know the mental impact on a person as they are going through this, and how movement helps with that. And I will dovetail this into saying that, I'm 43. I'm going to lump you into my generation, even though you're a couple of years younger. Our
I'm 40,
generation,
we're in there in the same
you're
decade
you're
now. Yeah.
so we're the first generation of women to have Title IX in our lives our entire life. And so we are accustomed to being a part of sports and having it be a part of our life and a part of our identity for a very long time. And so with that, also those diagnoses happening earlier, those younger people are going through this period of illness during their acute treatment. And then, as they're having longer treatments, post, I guess, the initial chemotherapies and radiation, that would probably be within like their first year of diagnosis and their longer treatments. They get taken out of their sport quite often because they're sick. And it's not also well understood or encouraged how much it might help for them to continue to be a part of that in a small way, in a less aggressive way throughout their treatment for their mental health and their physical health. So we're really, really concerned about white blood cell count, red blood cell count. We're less concerned about DEXA scans until they start to have fractures later on. Maybe we're boosting in a smaller way if somebody is quite young. But I think that there's also an issue of the choices that are being presented to people who are like me, who are previvors or who are early onset, where they say, well, you have the option of surgery, or you could do tamoxifen for 5 years, and that's going to put you into menopause, but you're young. So all of those risk factors that then increase so exponentially as you age, you're then having them in your 40s and for 40 to 50 more years of your life. And so I think there's a mismatch between our focus in keeping a person alive, which I think we're at a stasis with that, in terms of survivorship numbers. I think we need to start looking at a person as a whole person and saying, well, they don't want to just survive 1 of 5, want to live full, healthy, active lives as they are, surviving and living. And I think the data is just barely starting to support that and to recognize the significance in the loss of estrogen in these blocking mechanisms in this early, chemical and surgical menopause. And there was just a study that came out that showed, in the absence of estrogen, a group of women who were studied, they worked out 2 times a week at the same level of aggression as people who had estrogen, and how over a period of, it was a very short study, so I don't want people to get frustrated by it, but it showed that over a course of 10 weeks that they didn't have any changes in their muscle mass, or their fat mass. And the people who had estrogen did show a difference in muscle mass. They both showed an increase in strength, though, which I find to be interesting. And we know that strength and the perception of strength precedes muscle growth. So it's not to say that it's impossible, because we know it's not impossible, to add muscle mass and maintain bone density with heavy weight training, progressive weight training, but it's just to emphasize how very difficult it is. And so if we are having people who are experiencing that in their 20s and in their 30s and in their 40s, when they are 2, 3, and 4, 2 and 3 decades ahead of where the average person is for menopause, we need to recognize that high risk for sarcopenia and osteopenia, osteoporosis needs to be addressed immediately alongside all of the other treatments that they're experiencing.
And you make a really good point. Tamoxifen, for just to talk about that for a little bit, tamoxifen does put some people, it changes your hormones in your body. So some people stop getting their periods, or they get them regularly. Some people don't go into menopause on tamoxifen, but everything's kind of altered. But one of the things that we don't talk about often, and I make sure I do bone densities on everyone, tamoxifen or not. People think about menopause and osteopenia and osteoporosis, but tamoxifen in premenopausal women can worsen your bone density. And chemo, I see some, no one talks about this. And unfortunately, I would love to get pre-chemotherapy bone densities. Insurance doesn't always cover that, but I always get a post as a new baseline. And, I have people in their 30s who are coming with severe osteoporosis or very severe osteopenia, and they're in their 30s. And it may not bother them in their 30s, but how is that going to impact them in their 50s, 60s, 70s, 80s, and so forth? So there's just so much that we don't pay, I don't want to say don't pay attention to, but it's kind of pushed to the side, I think, sometimes in favor of, well, you need these treatments. And I think it's that thriving, and what is the quality of life, and what's the risk benefit? And that's where these conversations need to happen.
And there are great places that are just for breast and ovarian cancer. They're just for, female cancers. And they, in recent years, because I've been around this community for such a long time with my mom at 46, so I've been around it since I was, 17 years old. There are communities and they have things like acupuncture and massage therapy and sound therapy and pet therapy, these other options while you're in, they call it like the chemo lounge for your treatments. And we are recommending support groups, and we are recommending therapy, cognitive behavioral therapy, and we're recommending all of these other things. And I think that's great because that starts to look at the person as a whole person. But the longevity of cancer patients is hopefully improving. And because they're being diagnosed younger, hopefully they're going to live long, full lives. And we need to start planning for that, because cancer is still not the number one killer of women. And the loss of estrogen is directly related to cardiovascular disease in women, in Alzheimer's and dementia in women. And so these people are experiencing that in their 20s and 30s. They are going to be at severely high risk for all of those other things. And in some cases, a lot of cases, depending on the person, we can't replace with estrogen. We can't just say, hey, HRT is going to cure that for you once you're, X number of years out, once you clear. So we do everything that we can to improve their cardiovascular health, to improve their mental capacity, their cognitive capabilities through exercise. And I just went through a whole summer of training with an institute that worked with Alzheimer's to put together a program that is using brain games, but in a progressive way, like an exercise program would. And it was shown to work just as well as Alzheimer's medications for people who had mild to moderate dementia and Alzheimer's. And so we know that movement, we know that using your brain, it is still a use it or lose it mentality, both with our brains and our bodies. And we need to start putting those people into those programs that we know work much earlier and support them there with education, because you can't just say to somebody, go to the gym. They don't know what to do at the gym, even if they're someone who is in sports. We aren't allowed in the gyms when we're in middle school and high school. We'll go ahead and throw the boys in, but we're not throwing the girls in. And so that's a drum we're banging too, is to get the education for how to do a good squat. What is a good exercise program? What is progressive periodized training look like? But in the absence of having that, they need to have proper guidance. And so I'm hoping that within these centers, that these cancer communities, that we are also getting some really great people who are physical therapists, occupational therapists, strength and conditioning specialists, who have the background and training to work with these higher risk individuals, and to give them a scientifically led program that is going to improve their muscle mass, that is going to work on their hand-eye coordination, their balance, because falling is a huge risk for women as we age, and bone fractures from falling. And a lot of that starts with balance, which is hand-eye coordination, cognition. It's in your inner ear. It's grip strength. So we're talking about being able to hold on and grab onto something as you're falling. And it's flat out muscle mass. So you're talking about being able to catch yourself when you're falling, to work on that eccentric contraction as you're going downstairs, or the concentric contraction of getting up from a chair. And so these are all things that we can start working on with people who are experiencing that early onset menopause from day one. We can work on that and start that to start to work towards a better, healthier, longer life for them.
So one of the things that I hear and I see all the time is almost kind of treatment burnout or treatment fatigue, doctor fatigue. And I get it. People have gone, they've spent months coming to the cancer center. The GPS says, like, they get in the car and the GPS is like, are you going to the cancer center today? Right. So they're done with coming so often. And they're like, I can't commit to PT, or the financial toxicity of physical therapy, because that's a big one too. So how do we navigate that? And I don't expect you to have all the solutions, but I don't know. Well, how do we try to address it? Are there things that people can do at home? Is it worth going for one evaluation and then doing things at home? I try to meet people in the middle, but this one sometimes gets a little tough.
It is hard because, I mean, as you said, the fact that your GPS knows that at 11 o'clock in the morning that you're going to the cancer center is like, man, that is like
Yeah.
gotta be tough. And I really identify with patients who have general, physician fatigue, and you must do this one more thing. You have to change your diet. You have to do all these other things. Here are the new medications you're taking. Like, it is very overwhelming. I think one of the things that I have loved that I have seen start, and this is not just because you and I know each other, but you started those walks
Mhm.
where it was a group of people who are going on a walk with their physician. And a lot of time, I think walking gets a bad rap. It is a great gateway exercise to exercise. It's a great way to move your body, or as some people like to say, move your bones. It's a great way to connect with other people without looking at them. And so one of the things about cognitive behavioral therapy, and you and I know this because we're runners, is that you're never wanting to be, you're not always wanting to be looking at that person, because whatever
Yeah.
you're saying can be embarrassing, or you could filter yourself by their reaction on their face. Are they really paying attention? Are they really listening? And you're processing that while you're trying to talk, and you're intaking that. And so when you're walking or you're running with someone, you don't know what their facial expression is going to be, and you're not paying attention to that, and you're just sort of talking, or you're thinking when you're running, if you're or walking, or you're going by yourself. And so I think walking is a great way to connect with other people, especially people who are going through a similar thing as you. And I love it when centers have those walks. And it's also a great way to connect with others who might be going through the same thing at the same age, with the same concerns as you. The other thing that I would always suggest is, I always think with the good physical therapists, and I will qualify that by saying you definitely need a physical therapist or an occupational therapist who specialize in pelvic health with a strong background in orthopedics, if that is your desire to get back to a sport or activity, or if you're a fitness person. So you want someone who has both the pelvic health and the orthopedic background. I always think it's good to go for one. Tell them that you're there for one. Tell them when you walk in, I'm here for one visit and maybe a checkup in 6 months. And one of the things that I love to do with my patients is ask them, how much time do you really want to dedicate to this every day? Is it 2 exercises? Is it 3 exercises? And then I say, okay, it's 2, right, exercises. Here's the progression of each of those 2 exercises. It's 6 to 8 weeks for neuromuscular re-education. So honestly, you could do this for 3 months and do this exercise, do its progression. And that's 3 months, because that's, 6 weeks, and 6 weeks is 12 weeks. And I'll see you in 3 months. And if it's 6 months you want to see me, then I say, okay, and then here's 2 other exercises. And we take videos and we do that. So I think walking in, if you can get yourself there, walking in, telling them exactly what you're there for, what activity you want to get to, and how much time you have to dedicate to that is going to be the best way to get out of it what you want. And I would also say that one of the few good things to come out of COVID is access to telehealth. So I understand that physically getting yourself to and from might be difficult at any point in your treatment, and that there are a lot of pelvic health specialists like myself who are doing 50-50 in-person visits and telehealth, and we can do quite a lot on telehealth. People think, well, don't you need to see my vulva and vagina to see what's going on? Don't you need to touch and feel? And I will always tell them that the only point of an internal evaluation for me as a physical therapist who is seen a lot of this and done a lot of this and has it in my head, what I'm attuned to, the only reason is to confirm what I'm thinking, because I have an assumption based on what you're telling me, because that's the longest part of any evaluation. For me, it's like 30 to 45 minutes of someone talking to me and telling me about what they're experiencing. It's just confirmation bias when I go in there to touch the muscles. Sometimes I see something that's maybe unusual with the cluster of symptoms that they're saying, but very often it's what the patient is telling you, what they're telling you their symptoms are. And there's so much that you can do virtually. So if you have fatigue about getting to and from your appointments, I always tell people, DM me email me. I'm happy to help you find somebody in your area or in your state who will see you via telehealth. There are enough of us out there that there's somebody in every single state who's licensed in every single state. And to not be afraid of, shooting an email and asking for what you need. And if that clinic doesn't meet you with your needs, to definitely shop around and find someone who does.
I think that's huge. So for people listening to this, what are some of the common symptoms that signify some pelvic floor dysfunction?
Well, in people who are experiencing menopause, the genitourinary symptoms of burning, urinary tract infections, or symptoms like urinary tract infections,
Yep.
in the absence of actually having a urinary tract infection, the burning, the urgency, the feeling that your bladder is full, going to the bathroom and, oh, it was not full, there's actually nothing there. The feeling that you have to, you void your bladder and you stand up and you say, oh no, I have to go again. Stress urinary incontinence, I think, is more something people are familiar with, which is coughing, laughing, sneezing, jumping, and you have a leakage, an involuntary loss of urine or feces. Constipation, bowel urgency, painful intercourse. That's a big one as well. Dryness, any sort of irritation around your labia minora, labia majora. Um, those are probably the really big ones that people have. Overflow incontinence as well. If you have a full bladder and you're not able to make it to the bathroom, we say there's a key in the door syndrome, where sometimes you get to your front door, you have a full bladder, you're good, you're fine. You put the key in the door and suddenly you lose control of your bladder. But those are probably the biggest ones that we see. The genitourinary symptoms are really interesting because there are a lot of OBGYNs, urogyns, and oncologists like yourself who are banging the drum for vaginal estrogen, which can be, for some people,
Yeah.
when we're talking about a lack of estrogen to the musculature of the global body, and then we're saying, well, the muscles of the pelvic floor are exactly the same. Well, there's a place we can put estrogen right there. We can do a suppository up, and it's going to hit your pelvic floor, and then your pelvic floor is going to have estrogen. The rest of your body may not, but we can definitely do that when we're talking about cancer survivorship, when we're talking about menopause. It's also going to any burning, itching, stinging, bacterial vaginosis, that urinary tract infection like symptoms in the absence of having a urinary tract infection, or recurrent urinary tract infections, interstitial cystitis. These are all things that we see with pelvic floor, with that urgency. So I'm getting a patient whose symptoms are secondary to these primary problems of these infections or infection-like symptoms, the burning, the itching. And people say, well, is it a nerve thing? Is it something else? And I say, let's always try estrogen, because if you're a menopausal person, you're a cancer patient, I'm going to go ahead and say that you probably don't have estrogen support anywhere, and it's sometimes the thing. And then we can address the muscles. It's very hard to address the musculature of the pelvic floor if your symptoms are such that you are experiencing the one before, the genitourinary symptoms. There's a point where what I'm doing, I will max out on what I can do, and then I need to have a medicinal support. I need to figure out that root cause with your urogynecologist or your whoever is following up on your care, because the reaction that the muscles are having are to that primary driver. And then the primary driver is irritating and making those secondary muscle problems or nerve problems. So it's a back and a forth. And so then it becomes a 50-50, where one is not going to be the silver bullet, and we're going to need a combination of therapies in order to improve the patient's symptoms.
And I think what you bring up is a really important point, that it's not one person that's part of your team. I think oncologists, and I deal with this every day, is that you have very limited time with patients. And so we often will refer to all of the other specialists, the gynecologist, the urologist, the urogynecologist, pelvic floor PT. And again, I think sometimes that's frustrating for everyone, but understanding that oncologists are not pelvic floor experts, and that you do have to kind of bring in all of these other people who have the training and the experience and deal with this on an everyday basis.
Yeah, and I think it's secondary, right? The oncology portion is, to be blunt, something's trying to kill you. My job is to kill that thing.
Yeah,
And that's going to be the first thing that you do. And once that is started and there's a plan, once that's completed and the patient is moving on in some ways and they're being monitored, over a period of time, I think the follow-up can be lacking.
it
I
is.
think
It is.
people are left in a void sometimes. And
Mhm.
so, you know, unfortunately, I think sometimes the people who are picking those individuals up and taking them along are people who are less educated in what they actually need. And so then you have people who you know, are, fitness or nutrition gurus who don't have the education to really help these individuals optimize their diets in order to support the body that they have now and prioritize strength training and work with these people, because again, another byproduct of the lack of estrogen is in the lack of muscle mass is sometimes an increase in weight and increase in visceral fat. And that's frustrating for people. And then I've seen patients who have gone on these crash diets or who are following these people, and it's upsetting, but our medical system really does just sort of drop you off a cliff once we are no longer trying to keep you alive.
Yeah,
And I think physical therapy and occupational therapists who specialize in pelvic health are sometimes we become that point person for that person who's been dropped off. I say it all the time that I feel like my my understanding of when someone needs to be referred out and my follow-up surprises medical doctors because they don't have that time, because they're thinking of the patient in front of them, keeping them alive, all this kind of thing. And I'm seeing patients for much longer for that than that. And I'm maybe getting them back to running a marathon. And so I'm seeing them for years if they want to do that sometimes. And I think sometimes connecting and making that referral earlier can go a longer way to a person's follow-up, or at least that initial bug being put into their ear that like, oh yeah, this might happen. And when it does, or before it does, I need to see this person. And then that continuity of care can be carried over a little bit longer. So people aren't left to the Instagram fitness
that's
influencers.
that's exactly. I was just writing about this, that when people don't get all the information, they're going to go online. There they are. And if health professionals, people with certifications and training are not present in these spaces, they're going to the people that are trying to sell them thousands of dollars of unproven supplement cancer cures that are, nonsense, or like these crazy coaching programs for thousands of dollars. And but if we're not present in these spaces, that's who is.
Yeah, and I think people also feel more comfortable when we're talking about pelvic floor, genitourinary symptoms, sexual dysfunction, pain with sex. I think they're less likely to go to a person in person. They feel more comfortable looking online for this type of thing. And the people whose voices are elevated are people who look a certain way, have the right connections, and who can sell, who can market. And that's not always us.
Yeah.
Like that's not always us professionals. I say it all the time to my girlfriend whose husband is a photographer and photographs all of these incredible fitness models all the time. I tell him, I've said, I am never going to look like that. I am never going to photograph that way and be, half naked. I don't also want to be half naked on Instagram. And he always says it. He's always like, but you're so good at what you do. And people know you're so good at what you do and to talk about you. And I was like, that's so true. But but our patients are reticent to talk about sexual function, saying, I have incontinence, I have, I'm in perimenopause or menopause, and I'm experiencing, vaginal dryness, and I'm experiencing sexual dysfunction, as though it's their fault, or
Mhm.
it's the fault of the female body. It's betraying us, as opposed to it is something that every person who lives for any length of time into their 50s, every woman who lives into her
Yeah.
50s is gonna go through menopause. And I promise you, the skincare market is wonderful. You know how much I love my skincare. I am obsessed with all the things. But if my skin is dry, kind of suddenly as I'm aging, if my eyes drier because my hair is dry and I am putting moisture back into those, I promise you, you need to put moisture back into your vagina.
And
Full stop.
and vaginal estrogen, I can't tell you how many people say, I was told I can't have it. Well, why not?
Who told you that?
And I mean, every time I post about this, people are like, I was told I can't have anything. And I say, you know what, then push back a little bit, ask to see what what's the data,
What's your data?
and can we talk about it? And and I think the problem is that there is some data that says, well, maybe there's an increased risk in a small amount of people. Old study, old,
Old. I was just
old.
going to say, what year is your
Yeah.
education coming? Your study that you're going to show me that it's not good. If it's prior to the year 2015, I don't want to see it.
Well, that's the
I
problem. These
don't.
studies are old, and they're, part of it too is when we had different treatment. Like the whole thing is, but but again, you have this doctor-patient relationship, and patients are afraid to push back. And it's not pushing back. I think it's asking, it's empowering yourself. And that's why I try to do online, is really educate people to empower themselves to advocate for their health. But people are nervous about asking for that information, and then they leave and they feel like they weren't heard, or they didn't get their questions, or they're just afraid to ask about sex. I will tell you, I see
They
this
won't.
all the time. And so I will bring it up. I bring it up in everyone. I say, a lot of women experience issues with sexual health after cancer. Is that something and that's just the door. And maybe they're not ready to walk through, but at least they know the door is there. But ask for the data, ask for the studies.
Well, and I would even go a step further and say, follow somebody like you or like me or like Mary Claire Haver who post the studies, or, Dr.
Yeah.
Corinne Men, Kelly Casperson. They will give you the study. They'll give you the number to look for it
Yeah.
online. Bring that study in. Because if your doctor says no, say, then why? Because here's this study.
Mm-hmm.
And truly, I mean, there is also a place where when you are not feeling heard
Yeah.
by your physician, then you talk with your feet. And I understand that in some places, when you're at a certain place in your cancer treatment, that you can't, shouldn't, and it's like, do not
Absolutely.
do that then. That is not the time to be maybe, walking with your feet. But you could also get a second opinion. You
Yeah.
could also go to a urogynecologist, gynecologist, and have that discussion with them. And if they're a menopause specialist too, because that is a subspecialty that's coming out of urogyne and gynecology and obstetrics, is that subspecialty to treat people in menopause and postmenopause. Because here's a simple fact of the matter. You could be a gynecologist, an OBGYN, and not know a thing about menopause.
Yeah.
You can also be a physical therapist who knows not one single thing about pelvic floor, because all of my education is postdoctorate. There was one question on our exam, and it's the one question, and they tell you it's going to be one question about pelvic floor, and it's just what muscle surrounds the bladder, the detrusor muscle. That's it. Period. End of story. That's on the licensing exam.
Well, that
So we need to recognize that not everyone is a specialist, and you cannot keep up with all of the data. And so bringing it to your physician or finding a physician who does specialize in that can be the better way to improving those symptoms.
And I think the other part of this also, I mean, it's same thing for oncologists. We don't get any training in survivorship in none of that in fellowship. Everything that I've learned, honestly, 90% of what I've learned has been from my patients, telling them like, this worked, this didn't work, and from all of the amazing health professionals I interact with online and seeing their data. But I think the other piece of it is you're not taught that. Then most oncologists, depending on what part of the country you're at, we're in the New York, New Jersey area where most people specialize in one or two disease types. Right. But in other parts, in more rural areas, your oncologists are treating everything. So they're just thinking estrogen, breast cancer, no, that's it, right? Like it's not anyone's necessarily fault. But when you're trying to treat 20 different cancers and keep up with the literature, your priorities on which drug is going to keep someone alive.
And which one is not on back order.
Yeah. And
I mean, it's a lot. That's a full-time job.
It's a lot.
And, there are people like, Rachel Rubin is always reminding people that women are dying from bladder infections and kidney infection. It's incumbent upon, I think, primary care, urogyn, anyone who's seeing anybody who is menopausal to ask that question, which is, how is your bowel and bladder function? How is sexual function? So I think there are some physicians who just frankly don't have that question on their intake forms. They don't have it anywhere. And I think we all need to be attuned to it for our aging population, because look, in 1950, the average lifespan for women was 52 in America. We're now at what, 73?
Yeah.
So in my mother's lifetime, we have added 50% almost of the years to our life. And science needs to step into, and as physicians, we need to look at more at the whole person, and we need to step into this idea of chemical, surgical, early, late, middle, typical is something that is going to be treated by every physician. And because the symptoms are so broad, we're talking neurological symptoms, endocrinology symptoms, musculoskeletal systems, cardiovascular systems. You're hitting every single system. So every single physician needs to be attuned to that when they are seeing people who they know have had cancer treatment, who are in menopause, or people who are above the age of 35. You've got to start asking those questions, because sometimes it's as easy as vaginal estrogen. And that's an easy fix for patients.
And I forget who said this the other day, but it was someone who said, menopause isn't just the GYN's problem, so to speak.
No.
Right? It's like you said, it's every specialist. And I think it just kind of gets relegated to gynecology. And then you have a lot of people who maybe don't have their gynecologic organs anymore, right? So they're not routinely seeing the gynecologist. So then it's just like, okay, we're just not going to talk about menopause at all, which is, big. That's a whole other conversation.
That's a whole other topic. That's maybe a round table. That's several of us.
That's a step
crazy about that.
All right. So before we wrap up, because I think we could talk for hours, but I have a few kind of rapid fire questions. Okay. So when we think about pelvic floor, people talk about Kegels. Is that give me a 60-second thing on Kegels. Is that what are they all they're cracked up to be?
Yes. They are. The Kegel is an especially important exercise to be able to do, because you want to be able to flex, which is to pull up and contract, and extend, which is to bear down and push. That would be like saying, well, our bicep curls all are cracked up to be for the strength of the arm. Well, yeah, it's half of the arm. So yeah, it is kind of important. Is it the only focus? No, because are you using the bicep when you're doing a pull-up? Yes. So the importance of a Kegel is to be able to do it voluntarily, because you want to be able to do it when you need it. You want to be able to contract the intra-abdominal pressure of a cough, laugh, sneeze, run, lift heavy, all of those good things. But 70% of the muscle fibers of the pelvic floor are basically quietly on all the time, like your calf muscles are on all the time to keep you vertical. So once you train the pelvic floor to do those Kegels, and you're able to do that, and you have everything under control, then the global movements that you're doing, your lunges, your squats, your jumping and stuff, is going to also feed the strength of the pelvic floor. All of the muscles globally benefit from multi-directional, multifunctional exercises. So once you have rehabbed, if it needed to be rehabbed, the pelvic floor via Kegels and progressive exercises from there, and I like to say that if your pelvic floor therapist is only having you do pelvic floor therapy on your back on a table, for the entirety of your rehab and then they say you're fine, that's not true, because you need to get vertical and go against gravity. So you want to be able to reproduce that Kegel-like force, that quick strength in whatever activity is starting to be a provocative activity for you and bring about symptoms.
I do hear people say, but I do Kegel, so I don't need any more pelvic floor therapy.
Yeah, not true, because here's the rub, is that you could be doing them wrong.
Mhm.
A lot of people I have encountered who are like, I know how to do a Kegel, are Kegeling, but actually then they're bearing down. So they're doing it in an opposite direction. And neurologically, they've learned that. So we need to relearn how to do them properly. And for some people who say, I do Kegels, there's no, and I'm still having a problem, it's not the only problem. We can have muscles in the pelvic floor that are too tight, and you're not then able to to contract them and extend them fully. And so that tightness, I like to say, is fake strength. So it can hold on, but when it lets go, that's where we get that stress urinary incontinence. So Kegels are great. I need you to be able to do them voluntarily, but they're not the only thing. They're the thing, but they're not the only thing.
Perfect. And then last question is, what are, if someone is going to see a pelvic floor physical therapist or they're going to see a PT, are there any questions they should ask them to really make sure they're like a good pelvic floor PT? Like, what are the questions to ask? Or is there a specific certification? Like, walk me through that.
So there's two certifications that are really nationally the ones that you want to look for. Either the American Physical Therapy Association has a certification, or Herman and Wallace have certifications. So you want to make sure that they've gone through either one of those institutions for their postdoctorate training. And then after that, what I like to make sure that people are asking in terms of what is the right fit them is, a lot of people who come to me who are saying, I'm a runner, and this physical therapist didn't know how to get me back running. They could get me to where I was like getting around during my daytime, without my symptoms, but they couldn't get me running. And so you really want to see if you can find a physical therapist who has experience working with what your desired level of activity is to return to. Because you'll get some really wonderful physical therapists who primarily are working with more of a geriatric population. So their experience is not necessarily with people who are heavy lifters and CrossFit athletes. And so you want to make sure that your level of activity that you're desiring to return to matches the skill set beyond just pelvic floor therapy with whoever you're seeing.
And I would add to that conversation is really important with your oncologist, with your urologist, with your urogynecologist. I think, be very clear about where you are and where you want to be. Because
Your goals are so important.
yeah, I think that, and that goes beyond fitness and exercise. But I think, I see a lot of people who experience cognitive dysfunction from cancer treatment, and then that impacts their ability to go back to work. And so they're cleared to go back to work, but they say to me, but I can't go back to work because I can't perform at the level that I'm expected to, right? And so I think that having those really individual conversations is so, so important.
Yeah, I couldn't agree more. I think, in physical therapy for our documentation, patients' goals are something we have to ask. And I think in some other parts of medicine, a patient's goal is never asked.
Yeah.
It's never considered. And I would go a step further and say that in my own personal patient experience, the doctors who have gained my trust, who I still have relationships with, who I look to for my ongoing care, people who I text and say, hey, what's this like? They're the ones who also know me, who know I'm a runner. I can't tell you how many times during my various treatments, there have been physicians who have said, well, just don't run. It's not good for your body. Like right now, you're too anemic. Don't run. And I'm like,
No.
but like my mental health, my physical health, they just didn't see me as a whole patient. And it's important, even if you have time to shop around with your oncologist, to get someone who understands that you're a 20, 30-year-old person who is active, who wants to have an active sexual life, who wants to have a family, if that's something, you want to be able to say that. And if you don't feel comfortable saying that, if they're not asking those questions in that initial visit, if you have the time, if you have the bandwidth, if you have the opportunity, because the area has more than one person, I would say interview the other person, because some of these relationships are going to be lifelong, either the physician's life or the patient's life. And you're going to want to feel that you can have those conversations with your physicians as you go on in your life.
And you put your trust and your life into this person's hands. I mean, for me, when I was deciding about hysterectomy or not hysterectomy, one of the big conversations that my surgeon and I had was like, he's like, look, I know you want to get back to running. This is how we're going to help do that. And this is why I would recommend this technique with the surgery versus another one. And I think that really helped me, one, feel confident, but also feel comfortable that like, it wasn't just like it was more than this one procedure, right? That they were thinking about me as a whole person. And I think everyone deserves to feel that way.
I couldn't say it any better, and I agree wholeheartedly.
Abby, we could talk for a really long time, but I'm going to let you go. Before I do that, though, where can people find you? How do they connect with you? Give me all that info.
So you can find me at reformphysicaltherapy.com. You can find me at reformptnyc on Instagram. I'm not on the other platform really, because
You
it's a
could
terrible place.
it is a terrible place, but you know what I've learned? There's a lot of people on there looking for good information.
I know, and I should probably just have my Instagram connect to it so it automatically
Yeah, I
posts.
just
But
cross-posted it.
cross post it, because
Yeah,
as a human being, I am morally opposed to it.
sure.
But yeah, you can find me on the socials at Reform PT NYC, and you can always just shoot me an email, Abby at reformptnyc.com.
Thank you so much for being here.
Thanks for having me.